Welcome to the Deep Dive, your shortcut to being well-informed. Imagine you're in clinic and a patient just sighs, "I've tried everything, doc. Why can't I lose this weight?"
It's a really common frustration, isn't it? And something you, as future nurses, will definitely encounter, especially when you hear that obesity rates in the U.S. have hit, 43% of adults? That's nearly 1 in 2 people.
It is a staggering statistic, and it really highlights why this deep dive into obesity and its close relative, metabolic syndrome, is so vital.
Absolutely. We're tackling something complex today, often misunderstood. It's a global health challenge, really.
Yeah, and it's crucial to remember this isn't just about weight. We're talking about a chronic disease. It has profound impacts, on nearly every single body system.
That's the key shift in thinking.
So our mission today is to help you cut through the density of those med-surg nursing texts. We want to give you the essential nuggets from Lewis's medical surgical nursing.
Think of this as your shortcut, your aha moment generator for understanding the why and the how behind caring for patients with obesity.
Exactly. Stuff you can actually use in clinicals and, for the NCLEX too. We'll get into the science, the risks, and really focus on the nursing management.
Right, we'll cover patient assessment, priority interventions, even surgical options, and how metabolic syndrome fits into the picture.
We'll guide you step by step. Epidemiology, pathophysiology, assessment, classification, management, the whole spectrum. So let's unpack this.
So good.
So when we talk about obesity in a clinical setting, it's way more than just being heavy, isn't it? Let's start there, reframing how we even think about it.
Precisely. The technical definition is an excessively high amount of body fat or adipose tissue. But the really crucial insight, especially for you as healthcare professionals, is to view it as a chronic disease.
Like diabetes or hypertension.
Exactly like those. Not just a lifestyle choice, not a lack of willpower. That perspective shift changes everything about how we approach patient care. It emphasizes ongoing management, not a quick fix.
That's a powerful way to put it. And the numbers, wow, they really drive home the scale of this. About 43% of U.S. adults. But the disparities within that number are also pretty striking.
Yeah, the overall number is huge, but what's really insightful for us as nurses is how it connects to socioeconomic factors. You see the highest rates down south and in the Midwest,
Right.
and among Black and Hispanic populations. Nearly half of Black adults, around 45% of Hispanic adults. It's also more common in folks with lower incomes and less education.
And it starts young, too, doesn't it?
It does. More than 1 in 10 kids become obese as early as age 2 to 5. That has huge long-term implications for their health and for the patients you'll eventually be caring for.
Okay, so we get the basic energy imbalance idea, calories in versus calories out. But the underlying biology, the cellular stuff, that's where it gets really fascinating and maybe misunderstood. Can you walk us through that?
Sure. So at the cellular level, it's not just one thing. You get an increase in both the number of fat cells, this hyperplasia, and their size, which we call hypertrophy.
They get bigger and more numerous.
Exactly. And those individual fat cells, they can swell up like thousands of times their original volume to store fat. And here's a key point. When the existing fat cells get full, these precursor cells called preadipocytes get triggered.
Ah, so they make new fat cells.
Yeah, they differentiate into new adipocytes, mostly in that visceral fat, the deep belly fat, and subcutaneous fat just under the skin. And the biggest jump in fat cell number usually happens between infancy and adolescence. It kind of lays the groundwork.
Wow. So it's not just stretching existing storage, it's building new warehouses too. Does that lead to different types of obesity?
Well, yes, we differentiate. Most common is primary obesity. That's basically the energy imbalance we talked about, excess calorie intake.
Right.
But it's really important for you to remember secondary obesity. This is when obesity is caused by an underlying medical issue. Could be a congenital thing, an endocrine disorder like hypothyroidism or Cushing syndrome, maybe the CNS lesion, or even certain drugs.
The corticosteroids.
Corticosteroids, some antipsychotics, yeah. So during your assessment, you've got to keep those possibilities in mind.
Okay. And what about genetics? We hear so much about genes linked to obesity. How big a piece of the puzzle is that?
It's definitely a piece, the significant one. Over 400 genes have been linked, but having a genetic predisposition increases your risk. It doesn't, guarantee you'll become obese.
So genes aren't destiny here.
Not entirely. Think of genes as influencing things like appetite, satiety, that feeling of fullness, food cravings, even where your body tends to store fat, and how efficiently it stores calories. Family history is often a big clue.
Is there a specific gene example?
Yeah, the FTO gene, fat mass, and obesity-associated gene, that one's strongly linked. Certain versions, certain alleles, can actually increase appetite and reduce satiety. So people might genuinely feel hungrier or less full.
See, that really underscores that it's not just about willpower. There are these complex physiological mechanisms running in the background. Beyond genes, what about hormones? Which ones are key players in appetite?
Oh, it's incredibly complex. It's like this constant conversation between the hypothalamus in your brain, your gut, and your adipose tissue itself. Take leptin, for example.
That comes from fat cells, right?
Right. Normally, leptin tells your brain to suppress appetite and ramp up fat metabolism. But here's the paradox. Most people with obesity actually have high leptin levels.
High levels. Shouldn't that make them less hungry?
You'd think so. But it suggests leptin resistance. It's like the signal is being sent, but the brain isn't receiving it properly. Maybe the receptors are faulty or something else is interfering.
Okay, so the I'm full signal is broken. What about the I'm hungry signal?
That's largely ghrelin. It's a gut hormone that stimulates hunger. Normally, ghrelin levels shoot up when you're hungry and drop after you eat. Here's something fascinating, though.
Yeah.
In patients who've had gastric bypass surgery, they often don't get that same pre-meal spike in ghrelin. And that's thought to be a big reason why the surgery helps reduce hunger and promote weight loss.
So that's a great clinical link. You also mentioned adipokines earlier. What role do they play?
Ah, yes, adipokines. These are substances released by fat cells. They're not just passive storage bags. Adipokines are involved in glucose and lipid metabolism, insulin sensitivity, inflammation, immunity, vascular function, lots of things.
So what happens when there's too much fat, especially visceral fat?
With excess visceral fat, you get adipokine dysfunction. The balance gets thrown off. This directly contributes to insulin resistance, dyslipidemia, abnormal cholesterol levels, and high blood pressure. That's a major reason why that abdominal or android apple-shaped obesity is so strongly linked to serious health complications.
Yeah, so we have genetics, hormones, adipokines, but obviously the environment we live in plays a massive role too. How has that changed things?
Oh, hugely. I mean, just think about the increased access we have to cheap, high-calorie, energy-dense food, sugary drinks everywhere.
Portion sizes too.
Absolutely. Eating out often means way more calories and just enormous portion sizes compared to, say, 20 years ago. If you picture figure 45.5 in Lewis's, it shows how things like sodas, bagels, cheeseburgers have just ballooned. It's easy to take in way more calories without even realizing it.
And we move less.
Definitely. Technology, sedentary jobs, even leisure time spent gaming or online instead of being active. Economic growth paradoxically contributes sometimes.
And it's not always an equal playing field, right? Socioeconomic status matters.
It really does. In lower-income neighborhoods, there's often limited access to affordable, nutritious food. Fewer supermarkets with fresh produce, maybe no farmers markets. People might rely on cheaper, calorie-dense, nutrient-poor options.
And safe places to exercise might be lacking too.
Exactly. Fewer parks, maybe unsafe streets for walking or cycling. It all adds up, creating significant barriers.
And we can't ignore the psychosocial side. Food isn't just fuel for a lot of people.
Not at all. It's deeply tied to comfort, reward, social connection, often starting in childhood. Stress, sadness, anxiety, these can all trigger overeating.
Even just eating while distracted.
Yeah, eating mindlessly in front of the TV or while scrolling online. You can consume a lot of extra calories without even registering it. As nurses, understanding all these multifaceted triggers, the biological, environmental, psychosocial, is so important for effective patient education and support.
Okay, so putting it all together, what does this mean for patient health? What are the big health risks nurses absolutely need to be aware of?
Well, the most sobering fact is that mortality rates climb with increasing obesity, especially with that visceral abdominal fat. But here's the crucial message of hope you need to give your patients. Most of these obesity-related conditions can improve with weight loss. Even modest loss makes a difference.
So system by system, what are we looking at? Cardiovascular.
Big impact there. Obesity is a major risk factor for cardiovascular disease and stroke. That android, apple-shaped obesity, is the strongest predictor. It's linked to increased LDL, bad cholesterol, high triglycerides, and decreased HDL, good cholesterol. Plus, hypertension is common due to increased blood volume, inflammation, even sleep apnea contributing.
And metabolic health. Diabetes.
Obesity is the single greatest risk factor for type 2 diabetes. It fuels that whole cycle. Hyperinsulinemia, insulin resistance, the pancreas getting overworked trying to keep up, decreased helpful adipokines like adiponectin. It's a cascade.
Okay. What about GI and liver?
Increased risk for GERD, gallstones, because cholesterol metabolism gets altered, and significantly non-alcoholic steatohepatitis, or NA and ASH. That's fat building up in the liver, causing inflammation, and it can actually progress to cirrhosis. It's a serious consequence.
And breathing, slip.
Definitely affected. Extra fat around the neck contributes to sleep apnea. The weight on the chest wall can lead to obesity hypoventilation syndrome, making breathing harder work. And poor sleep itself can mess with appetite hormones like leptin, potentially worsening the cycle.
Musculoskeletal problems seem obvious with the extra weight.
Yes, osteoarthritis, especially in weight-bearing joints like knees and hips, is very common due to the mechanical stress. But inflammation plays a role too. Obesity is also linked to hyperuricemia and gout.
And cancer risk, that one might surprise some people.
It's a critical link. Obesity is considered one of the most important preventable causes of several cancers: breast, colorectal, endometrial, kidney, liver, ovarian. The list goes on. It's thought to be related to hormonal factors like increased estrogen from fat tissue, altered insulin levels, and those adipokines causing chronic inflammation.
Wow. And finally, the psychosocial toll can't be understated.
Absolutely not. Patients often face significant stigma and discrimination in jobs, education, even sometimes within healthcare itself, unfortunately. This can lead to low self-esteem, social isolation, loneliness, and major depression. Addressing this emotional and social burden is just as vital as managing the physical health issues.
So managing this complex condition really starts with a thorough assessment. And for us as nurses, there's a crucial first step before we even interact with the patient.
You're absolutely right. It's self-assessment. We must examine our own beliefs, our own biases about obesity. Do we subconsciously link it to laziness or lack of willpower? Because if we do, we might unintentionally convey judgment or shame, which completely shuts down communication and trust.
A non-judgmental, sensitive approach is absolutely key.
Paramount.
So once we've done that internal check, what goes into a good nursing history and physical for a patient with obesity?
Okay, first, sensitive questioning. Use open-ended questions. Ask about their weight history, any family history of obesity, how their weight impacts their daily life and health, what food means to them, comfort, stress relief, social connection. Get a sense of their typical diet, their motivation level for making changes now, what they've tried before, what barriers they face, their exercise habits, their support systems.
And assessing their readiness is key, you mentioned.
Yes, critically important. If a patient isn't ready to make changes, pushing them won't help. Acknowledge that, provide resources, and let them know the door is open when they're ready. Don't make them feel like a failure for not being ready today.
Good point. What else in the history?
Explore potential secondary causes. Ask about symptoms of hypothyroidism, PCOS, Cushing's. Review their medications. Then you'll anticipate orders for lab tests: liver function, thyroid function, fasting blood glucose, and a full lipid panel, triglycerides, LDL, HDL.
And assess for existing complications, too.
Definitely. Screen for hypertension, symptoms of sleep apnea, signs of diabetes or prediabetes if not already diagnosed.
Okay, moving to the physical exam, it's more than just the number on the scale, right?
Oh, absolutely. Of
Uh-huh.
course you get height and weight, and do this respectfully in a private area if possible, using an appropriately sized gown. But here's a huge practical takeaway for you as students. Ensure you have appropriately sized equipment.
That's so important for patient dignity and accuracy.
It really is. Appropriately sized chairs in the waiting room and exam room, a sturdy examination table, a scale that can handle higher weights, and crucially, large and extra large blood pressure cuffs. Using a cuff that's too small will give you a falsely high reading.
Good reminder. What else are we measuring?
Waist circumference. Measure it just above the iliac crests and calculate their BMI.
Okay, let's talk about those classifications. BMI is the most common one we hear about.
It is body mass index, or BMI, calculated as weight in kilograms divided by height in meters squared. The categories are: underweight is less than 18.5, normal is 18.5 to 24.9, overweight is 25 to 29.9, then obesity starts at 30, class 1 is 30 to 34.9, class 2 is 35 to 39.9, and class 3, often called extreme or morbid obesity, is 40 or greater.
But BMI isn't the whole story, is it? What are its limitations that we need to keep in mind?
That's a really important point. BMI doesn't differentiate between muscle mass and fat mass.
Hmm.
So a very muscular athlete might have a high BMI, but be perfectly healthy metabolically.
Right.
Conversely, an older adult who has lost muscle mass sarcopenia might have a BMI in the normal range, but still have excess body fat percentage, putting them at risk. So you need to consider it alongside age, gender, and overall body composition.
So what other measurements help paint a clearer picture?
Waist circumference is key because it's a good indicator of visceral fat, that dangerous abdominal fat. Health risks significantly increase if the waist is over 40 inches in men or over 35 inches in women. We also sometimes look at the waist-to-hip ratio, WHR, though waist circumference alone is often used clinically now.
And body shape matters too. The apple versus pear.
Yes, we classify body shape, broadly, into android, apple-shaped, or gynoid, pear-shaped. Android obesity, with fat concentrated in the abdominal area, carries a much higher risk for cardiovascular disease, diabetes, and hypertension. Gynoid obesity, with fat mainly in the upper legs and buttocks, has a better prognosis regarding those specific risks. The fat there can be harder to lose.
Okay, so we've done a thorough sensitive assessment. Now, what's the plan? What are the big picture goals for patients, and how do we as nurses help them get there?
The overall goals are usually to help the patient modify their eating patterns, incorporate regular physical activity, achieve and maintain a healthier weight, and very importantly, minimize or prevent those health complications we talked about.
And it's tough. It's a lifelong commitment.
It absolutely is. And that's where setting realistic goals is crucial. Even a modest weight loss, maybe 5% to 10% of their starting weight, can lead to significant improvements in blood pressure, blood sugar, and cholesterol levels. Aiming for a sustainable loss of 1 to 2 pounds per week is generally realistic.
What's the nurse's role in this process?
Our role is huge. We act as educators, motivators, coaches. We help build that internal motivation using techniques like motivational interviewing, exploring their reasons for wanting change. We provide accurate information about healthy eating and exercise. We help them track progress, maybe weekly weigh-ins, same time, same clothes, avoid daily weigh-ins due to normal fluctuations, encourage food or activity journals to identify patterns.
So it's really a holistic approach, isn't it?
Totally. The best plans combine nutrition therapy, exercise, behavior modification, and sometimes drug therapy or even bariatric surgery might be considered. They all work together.
Let's break those down. Nutrition therapy, what's the focus there?
Nutrition is the cornerstone. It's fundamentally about creating a calorie deficit, consuming fewer calories than the body expends. But importantly, research shows that adherence to a reduced calorie plan is more important than the specific type of diet, low carb, low fat, etc. The best diet is one the patient can actually stick with long term.
So what kind of general dietary advice should nurses give?
Emphasize variety. Plenty of fruits, vegetables, whole grains. Choose lean protein sources and low-fat dairy. Limit saturated and trans fats, cholesterol, sodium, and especially added sugars. Drink plenty of water and avoid sugary drinks and excess alcohol. Those are major sources of empty calories.
Portion control must be a big part of that conversation too.
Huge.
Yeah.
Many people are honestly unaware of what a standard serving size looks like anymore. Using visual cues can be really helpful. Each patient's things like a woman's fist or a baseball is about a cup, good for fruits or veggies. The palm of their hand, or a deck of cards, is roughly 3 ounces of meat. A thumb tip or 6 dice is about an ounce of cheese. Those visuals make it much more concrete.
That's practical advice? What about fad diets?
Strongly discourage them. They might lead to quick initial weight loss, but they're rarely sustainable, often nutritionally unbalanced, and usually result in weight regain, sometimes even more than was lost. We want sustainable lifestyle changes.
Okay, moving on to exercise. What are the targets?
The general recommendation is at least 150 minutes of moderate intensity aerobic activity, think brisk walking, cycling, swimming per week, or 75 minutes of vigorous intensity activity. But for maintaining weight loss, studies suggest more might be needed, maybe 200, 300 minutes per week.
How can nurses help patients integrate that into their lives?
Encourage finding activities they actually enjoy and integrating it into daily routines. Park farther away from the store entrance, take the stairs instead of the elevator, break it up into smaller chunks if needed, like 3 10-minute walks a day. The key is consistency. And one safety point. Caution patients, especially if they're deconditioned, against doing intense weekend warrior type exercise only, as that can increase injury risk.
Makes sense. Now, behavior therapy, that sounds really important for changing habits.
It's incredibly powerful. It focuses on helping patients understand and modify the behaviors around eating and activity. A core technique is self-monitoring.
Like keeping a food diary.
Exactly. Recording what, when, where, and maybe even why they ate, along with activity levels and weight. This helps identify patterns, triggers, and problem areas. Another technique is stimulus control.
What's that?
It's about managing the environment to reduce cues that trigger unwanted eating. For example, if someone always snacks while watching TV, maybe restricting eating to only the kitchen table helps break that association. Or not keeping tempting foods in the house.
And rewards.
Yes, but non-food rewards.
Yeah.
Praising success and setting up small rewards for reaching milestones like a relaxing bath, buying a new book, spending time on a hobby can really help maintain motivation.
Support groups can play a role too, right?
Absolutely. Groups like TOPS, Take Off Pounds Sensibly, or WW, Weight Watchers, provide peer support, share tips, and accountability. Commercial programs like Jenny Craig or Nutrisystem offer structured plans and prepackaged meals, which works for some, but cost can be a barrier.
Okay, let's talk about drug therapy. When does that come into play?
Drug therapy is always considered an adjunct, something added to diet, exercise, and behavior therapy, not a replacement for them. It's typically reserved for patients with a BMI of 30 or higher, or a BMI of 27 or higher if they also have significant weight-related health problems like hypertension or type 2 diabetes.
And what's the nurse's role when a patient is prescribed weight loss medication?
Our role involves teaching proper administration, explaining potential side effects, and managing expectations. Patients need to understand these drugs aren't magic pills. Weight regain is likely if they stop the medication without maintaining those lifestyle changes. And importantly, always advise patients against using over-the-counter diet pills or supplements without talking to their healthcare provider first. Some can be ineffective or even dangerous.
Can you give examples of types of medications used?
Sure, they work in different ways. Some act centrally in the brain to reduce appetite or increase satiety. Examples include fenimidopyramide, Fusia, or newer injectable drugs like liraglutide, Saxenda, or semaglutide, Wegovy, which mimic gut hormones. Another type works in the gut to block fat absorption, like orlistat, Xenical.
What's a key nursing point for orlistat?
With orlistat, patients must follow a low-fat diet, generally less than 30% of calories from fat, spread over meals, to minimize unpleasant GI side effects like oily spotting, flatulence, and fecal urgency. Counseling on dietary fat intake is crucial for adherence.
Okay, that covers lifestyle and medical management. Now let's shift to bariatric surgery. This is a major intervention.
It is, and currently it's considered the only treatment that provides successful and lasting weight loss for individuals struggling with extreme obesity.
What are the criteria for being considered for bariatric surgery?
Generally, it's a BMI of 40 or greater, or a BMI of 35 or greater if the patient also have at least one significant obesity-related comorbidity, think type 2 diabetes, severe hypertension, heart failure, severe sleep apnea, or liver disease related to fat.
What are the potential benefits? They must be significant to warrant surgery.
They really are. Patients often experience a dramatically improved quality of life. Many see remission or significant improvement in their diabetes, sometimes very quickly after surgery. Blood pressure often normalizes, cholesterol levels improve, GERD and sleep apnea frequently resolve or get much better.
But it's not a simple decision. There's a screening process.
Oh, absolutely. It's rigorous. Patients undergo psychological screening to assess for conditions like untreated depression, binge eating disorder, or substance abuse that could interfere with post-op success. They also have thorough physical screening to identify any underlying illnesses that might make surgery too risky or limit life expectancy, and to ensure they're capable of adhering to the extensive post-op care and lifestyle changes. Insurance coverage often requires documented participation in medically supervised weight loss programs first.
Okay, let's talk about the main types of surgeries nurses should be familiar with. Maybe start with the restrictive ones.
Sure. Restrictive procedures primarily work by reducing the size of the stomach, which limits how much food a person can eat at one time. Digestion itself isn't significantly altered. A common example now is a sleeve gastrectomy, often called the gastric sleeve.
How does that work?
About 75% of the stomach is surgically removed, leaving a narrow, tube-like or sleeve-shaped stomach holding maybe only 2 to 5 ounces. This not only physically restricts intake, but also removes a large part of the stomach that produces ghrelin, the hunger hormone, so patients often feel less hungry.
What are the downsides?
Well, it's not reversible because stomach tissue is removed. And like any surgery involving stapling or cutting the stomach, there's a risk of leaks from the staple line.
Okay, what about procedures that are both restrictive and malabsorptive?
The classic example, and still considered a gold standard by many, is the room-wide gastric bypass, or RYGB.
How is that different?
With RYGB, the surgeon creates a very small stomach pouch, maybe the size of an egg. Then they bypass a large portion of the stomach and the first part of the small intestine, the duodenum and some jejunum, by connecting the pouch directly to a lower part of the small intestine, the jejunum.
So it restricts intake and reduces nutrient absorption.
Exactly. It leads to excellent weight loss, often more than the sleeve alone, and has a very powerful effect on improving comorbidities like diabetes, often very rapidly.
But there must be drawbacks too.
Definitely. It's a more complex operation than the sleeve. It's generally not reversible. There are risks of leaks, ulcers where the intestine is joined, hernias and gallstones later on, and because you're bypassing the part of the intestine where many nutrients are absorbed, there's a high risk of long-term nutritional deficiencies.
Which nutrients specifically?
Iron, vitamin B12, cobalamin, folate, calcium, and vitamin D are common ones. Lifelong vitamin and mineral supplementation is absolutely essential. Another potential issue is dumping syndrome.
What's dumping syndrome?
That's when sugary or high-fat foods move too quickly from the small stomach pouch into the small intestine, causing unpleasant symptoms like nausea, cramping, diarrhea, dizziness, and rapid heartbeat shortly after eating. Patients learn to avoid trigger foods.
Given how major these surgeries are, the nursing care before and after must be incredibly important and specialized. What are the key preoperative nursing considerations?
Pre-op care is vital for setting the patient up for success. As nurses, we need to do a thorough assessment, focusing on those comorbidities, any assistive devices they might need after surgery, and their baseline pulmonary function. Again, ensuring you have appropriately sized equipment is critical. Gowns, beds that can support their weight, the right BP cuffs, maybe bariatric-specific transfer equipment like lifts or walkers.
Are there assessment challenges specific to these patients?
Sometimes. Auscultating heart and lung sounds can be difficult due to a thicker chest wall. An electronic stethoscope can help amplify sounds. Getting 4V access can also be challenging due to deeper veins or shifting subcutaneous tissue. Longer catheters might be needed.
And patient education before surgery.
Absolutely crucial. You need to teach them before surgery about coughing, deep breathing exercises, using the incentive spirometer, how to turn and position themselves to prevent complications. If they use a CPAP machine at home for sleep apnea, make sure arrangements are made for them to have it and use it immediately after surgery in the hospital.
Okay, surgery's done. What are the immediate post-operative nursing priorities?
Airway, breathing, circulation, the ABCs, always. But with bariatric patients, there's a specific risk of resedation. Anesthetics can be stored in adipose tissue and get released slowly after surgery, potentially causing drowsiness or respiratory depression when you least expect it. So vigilant monitoring is key. Be ready to perform a head-tilt jaw thrust if needed.
How can we help their breathing?
Keep the head of the bed elevated, usually at least 30–45 degrees. This reduces pressure on the diaphragm from the abdomen and helps maximize lung expansion. Ensure they're receiving oxygen as ordered. And start that pulmonary hygiene, deep breathing, coughing, incentive spirometer right away.
What about preventing blood clots, VTE prevention?
Extremely important due to reduced mobility and inflammatory changes after surgery. Anticoagulants will likely be ordered, perhaps compression devices, but early and frequent ambulation is the cornerstone. Get them up and walking, even just short distances, the evening of surgery if possible, and then multiple times a day. Diligent turning if they are bedbound initially.
And the surgical site? Wound care.
Monitor the incision closely for any signs of infection, redness, warmth, drainage. Pay special attention to skin folds. Keep them clean and dry to prevent moisture-associated skin damage or fungal infections. Implement pressure injury prevention strategies. And be incredibly alert for signs of an anastomosis leak.
Remind us what those signs are again.
A leak where the stomach or intestine was surgically joined is a potentially life-threatening complication. Signs include tachycardia, fast heart rate, fever, tachypnea, fast breathing, increasing abdominal pain, or sometimes shoulder pain. It can be subtle initially, so a high index of suspicion is needed. Any significant change in vital signs or pain warrants immediate investigation.
Nutrition after surgery sounds like a very careful process.
It is, and it requires meticulous patient education. They typically start with small amounts of low-sugar, clear liquid, maybe 15 milliliters, half an ounce, every 10–15 minutes. Gradually increasing volume is tolerated, aiming for maybe 90 milliliters, 3 ounces, every 30 minutes within a day or so.
What should they avoid?
No gulping, no straws can introduce air, no caffeine initially, and definitely no sugar-sweetened beverages. After maybe 48 hours, if tolerating clears, they advance to a low-calorie, full liquid diet, then pureed or soft foods for a couple of weeks, before slowly progressing to a more regular solid food diet, usually around 4–6 weeks post-op.
What are the key principles for their long-term diet?
It needs to be high in protein to aid healing and preserve muscle mass,
Mhm.
relatively low in carbohydrates and fat. They need to eat 6 small meals a day rather than 3 large ones, a crucial point. No drinking fluids with meals or for about 30 minutes before and after. Fluids can wash food through the small pouch too quickly, causing dumping syndrome or preventing adequate nutrient absorption. They also need to eat very slowly, chew thoroughly, and stop eating the moment they feel full. Avoiding high-calorie, low-nutrient foods is essential for long-term success.
What about long-term care once they go home?
Continued dietary adherence is paramount. Regular follow-up with a surgeon and a registered dietitian is key. And as we mentioned, lifelong vitamin and mineral supplementation is non-negotiable, especially after malabsorptive procedures like the RYGB. They'll need a comprehensive multivitamin, plus extra calcium, vitamin D, iron, folic acid, and vitamin B12, often via injection or sublingual form because absorption in the stomach is altered. Regular lab monitoring is needed to check for deficiencies.
Are there other long-term complications to watch for?
Yes, things like peptic ulcers, dumping syndrome can persist. Small bowel obstructions can occur years later due to adhesions.
And the psychosocial aspect continues to be important.
Very much so. Assess how they're adjusting socially, changes in self-esteem, body image concerns. Some patients feel guilt or shame about needing surgery. Rapid, massive weight loss can also lead to large amounts of excess flabby skin, which can be physically uncomfortable and emotionally distressing. Figure 45.10 in the book shows pre- and post-op pictures of cosmetic surgery to address this. Referral for counseling or support groups can be very beneficial.
One more point for women.
Yes, fertility often improves significantly after weight loss. It's crucial to advise women of childbearing age to use reliable contraception and postpone pregnancy for at least 12 to 18 months after surgery, allowing their weight and nutritional status to stabilize first. Pregnancy soon after surgery carries risks for both mother and baby.
So evaluating success isn't just about pounds lost.
Not at all. Evaluation focuses on achieving and maintaining a healthier weight, yes, but also on improvement or resolution of comorbidities, successful integration of healthy eating and exercise habits, freedom from surgical complications or side effects, and improved overall quality of life and self-image.
Okay, let's pivot slightly and connect this back to metabolic syndrome. It's often mentioned alongside obesity. What exactly is it?
Right, they're very closely linked. Metabolic syndrome isn't one specific disease itself. It's actually a cluster of metabolic risk factors. Having this cluster significantly increases a person's risk of developing cardiovascular disease, CVD, stroke, and type 2 diabetes.
How common is it?
It's incredibly common.
Yeah.
Affects over 1 in 3 adults in the U.S., and the prevalence really climbs with age, hitting about 50% in people 60 and older. But we're also seeing concerning increases in younger adults, even those in their 20s and 30s.
How is it diagnosed? What are the specific criteria nurses need to recognize?
The diagnosis is made if a person has 3 or more of the following 5 conditions. You can remember these easily. 1, increased waist circumference, that abdominal obesity marker we talked about, a 40 inches for men or 35 inches for women.
Okay, waist size. What else?
2, elevated triglycerides, 150 milli-GDL, or R if they're already on medication to treat high triglycerides. 3, low HDL cholesterol, the good cholesterol, 40 milli-GDL for men or 50 milli-GDL for women, or R if they're on medication for low HDL.
Got it. Triglycerides and HDL. 2 more.
4, elevated blood pressure, a 130 millimeter Hg systolic, or R, a 85 millimeter Hg diastolic, or as if they're on medication for hypertension. And 5, elevated fasting blood glucose, 100 milli-GDL, which is in the prediabetes range, or R if they're on medication for high blood sugar.
So 3 out of those 5 gets you the diagnosis. What's the underlying connection? Why do these things cluster together?
The main underlying factor, the driver behind it all, is believed to be insulin resistance, which is strongly related to that excess visceral fat. When cells become resistant to insulin, the pancreas tries to compensate by pumping out more and more insulin, leading to hyperinsulinemia.
And that causes problems.
Yes, this whole cascade, the insulin resistance, the hyperinsulinemia, contributes directly to developing hypertension, increases the risk of blood clots, causes abnormal cholesterol levels, high triglycerides, low HDL, and ultimately significantly boosts the risk of coronary artery disease and diabetes. Figure 45.11 shows this visually.
So how do we manage metabolic syndrome from a nursing perspective? Is there a specific treatment?
There isn't one single pill for metabolic syndrome itself. The absolute cornerstone of management is lifestyle modification. That means aggressive efforts towards weight loss, especially targeting that abdominal fat, increasing physical activity, adopting a heart-healthy diet like the DSH diet or Mediterranean diet, and definitely smoking cessation if they smoke.
So it sounds very similar to the management of obesity itself.
It is, because addressing the underlying obesity and insulin resistance is key. Of course, medications are often needed, but they target the individual components. So patients might be on cholesterol-lowering drugs like statins, antihypertensive medications, or drugs to lower blood glucose like metformin, which also helps improve insulin sensitivity. And for obese patients who meet the criteria, bariatric surgery can be very effective in reversing metabolic syndrome.
This has been a really thorough overview. Now, to help solidify this for our listeners, let's work through a couple of brief clinical scenarios. How about this first one? You have a 54-year-old male patient. He's 5'9", weighs 242 pounds, putting his BMI around 37. His blood pressure is uncontrolled. During the visit, he gets angry and refuses to even discuss changing his diet or exercise habits. How would you, as the nurse, respond in that moment?
That's a tough but common situation. The key is not to get defensive or push harder. First, acknowledge his feelings. I can see you're feeling frustrated right now. Then maybe try some motivational interviewing. Gently explore his perspective. Can you tell me more about why changing diet or exercise doesn't feel possible right now? Assess his readiness without judgment. Maybe he's just not ready today. You could say, okay, I understand this isn't something you want to focus on today. Perhaps we could revisit it at a future appointment. Offer resources, but don't force them. The goal is to keep the door open for future conversation, not win an argument.
Excellent approach. Okay, here's a more detailed case. SR is a 48-year-old woman. She comes in reporting hip pain and says she's gained about 40 pounds over the last 20 years. She admits she's pretty sedentary. Her history includes type 2 diabetes, hypertension, she gets short of breath sometimes, has osteoarthritis. She actually had a knee replacement at 46 and she tried orlistat in the past but stopped it. Today she weighs 230 pounds, BMI is 37, waist circumference is 40 inches, BP is high at 160/100, and she has moderate hip pain on exam. Her labs show a fasting glucose of 250, total cholesterol 205, triglycerides 298, HDL only 31, and LDL 114. So, thinking about SR, what are her major risk factors and existing complications of obesity? Would she potentially be a candidate for bariatric surgery? And what would be your priority in nursing interventions and teaching points for her?
Okay, well, SR really embodies many of the issues we've discussed. Her risk factors include her age, sedentary lifestyle, and likely dietary patterns contributing to the weight gain. Her existing complications are significant: uncontrolled type 2 diabetes, glucose 250, hypertension 160/100, dyslipidemia, high triglycerides, low HDL, shortness of breath, possibly obesity, hypoventilation, or deconditioning, and severe osteoarthritis requiring joint replacement. Her waist circumference of 40 inches puts her at high risk. Given her BMI of 37 and multiple serious comorbidities, diabetes, hypertension, she does meet the criteria for bariatric surgery evaluation. Priority nursing problems include ineffective health management, imbalanced nutrition, activity intolerance, risk for cardiovascular events. Priorities for teaching would involve education about her conditions, the critical need for blood sugar and BP control, exploring readiness for lifestyle changes, diet, activity within her pain limits, discussing realistic weight loss goals, reviewing medication adherence, and potentially initiating the conversation about bariatric surgery as a treatment option, explaining the risks, benefits, and extensive commitment involved.
That's a great breakdown. One last scenario, focusing on the psychosocial aspect. Imagine you walk into the room of a 36-year-old woman who recently had bariatric surgery. She's distraught, crying, and says, I feel like such a failure. I couldn't lose weight on my own. I had to have this horrible surgery. How do you, as her nurse, respond to that?
That's heartbreaking to hear, but also not uncommon. The first step is therapeutic communication. Sit down, make eye contact, use active listening, validate her feelings. It sounds like you're feeling really discouraged and maybe even guilty about having surgery. Avoid minimizing your feelings or just jumping to positives. Acknowledge the psychological toll this journey takes. Gently reframe surgery not as a failure, but as a powerful tool to treat a complex chronic disease, obesity. Remind her that obesity involves powerful biological factors that make weight loss incredibly difficult for many people. It's not just about willpower. Explore her expectations versus the reality of recovery and life after surgery. Assess her support systems, and strongly encourage connection with post-bariatric surgery support groups and possibly referral for counseling to address body image issues, coping mechanisms, and feelings of guilt or failure. She needs ongoing support.
These scenarios really drive home the need for that compassionate, holistic nursing care, don't they?
Absolutely. It's about treating the whole person, physically and emotionally.
Well, today we've certainly taken a deep dive into obesity and metabolic syndrome. We've seen them not just as weight issues, but as complex, chronic, multifactorial diseases that touch nearly every part of the body.
And we've highlighted how critical your role as a nurse is, from that initial empathetic, non-judgmental assessment.
Right, all the way through guiding patients in managing complex plans, whether that's lifestyle changes, medications, or the really intricate care needed before and long after bariatric surgery.
Remember the power of that holistic view, and that even small sustained weight loss can make a huge difference in your patient's health and their quality of life.
Definitely. So, as you move forward in your careers, here's a final thought to consider, something beyond the individual patient encounter. How can we as nurses advocate for bigger changes?
Yeah, things like advocating for community or policy initiatives that improve access to affordable, healthy food or create safer environments for physical activity. How can we help shift the tide of this epidemic on a larger population level?
Something important to think about. You are all going to be the knowledgeable, skilled, and compassionate nurses our world desperately needs. Thank you for joining us on this deep dive.
Thanks for listening. This has been a deep dive from the Last Minute Lecture team.